Okay, so now we are recording. So first of all, thank you all for joining this first webinar of the International Society for Environmental Epidemiology Eastern Mediterranean chapter. And we are very delighted to have all of you here. Myself, I'm chairing the chapter, and Dr. Nargis Khanjani is the co-chair, and she's also on the webinar. And we have today presentations ranging from Pakistan on one end of the region and Morocco on the other end. And then we have Yemen, Iraq, Palestine, and Lebanon. So we have a very good range, and we will try and limit each talk to 10 minutes. And then if you go over the 10 minutes, we will have to, stop the presentation, and then we won't have time for question and answer. So please try and time that. I will try and give a warning of 2 minutes before the time. So I'm going to just randomly pick somebody to start, but let's start with, we have the two colleagues from Pakistan, and I want to start with Dr. Zafar, who is going to present some of their recent study data on some of the attitudes and beliefs about COVID-19. So, Dr. Zafar, can you share your presentation, please?
Is it visible?
Yes, the floor is yours.
Great. Yeah, thank you, Wael, and everybody else. So happy Ramadan and good evening from Pakistan, and hopefully there's good afternoon there in the region. So still sun is up. So I'll be quick in my presentation, and I hope that you get what I'm trying to say over here. So we did a knowledge, attitude, and practice survey quickly among the population, among the three subpopulations in Pakistan: the rural population, urban population, and also population which has access to WhatsApp and media. So the three subpopulation, we did, and we quickly got the knowledge, attitude, and practices and the gaps they had. So the people who were part of this are listed here. So normally for a scientific presentation, I would have started with the rationale, but it all looks so redundant here that every one of you would have all the counts of COVID in your head already. So not talking about COVID. So majority of the health determinants and health lies in the hands of the people. As a public health people, we know that, and community has the has the strength in controlling that, and obviously not hospitals. But COVID has made that very obvious, and our hope to manage this disaster lies in the population's good behavior. So health literacy, supports attitude and both supports practice, and this is quite known phenomena. And if you have a good practice, then you can prevent and protect yourself. Jumping on directly to what we did as a cross-sectional study among over 900 people, adults who were above 18 years old, and they were males and females in three subpopulations. So a survey, those who had smartphones and internet connections, so through WhatsApp, through email, we contacted them throughout Pakistan, and 403 individuals were, responded through that. And then we had another sample, which was actually from the previous study in megacity Karachi. We had clusters and the telephone numbers available. So we telephoned randomly selected individuals in 30 clusters, which is called primary sampling units in Pakistan, which is based on Bureau statistics. So quite representative sample. That's what I'm trying to say. So those were the urban sample of 365 adults based, and they were contacted through telephone. And then there was a rural population who were actually contacted through face-to-face interviews. And this was the rural health program we have at Aga Khan University. So we have the population in Thatta district, one of the rural district. So we had conducted face-to-face, keeping all the practices which is required to be safe. But this survey was stopped in between, had to be stopped because of the lockdown. So the survey had only 137 individuals. So if you see the differences in the demographic of the three surveys, so more females, 76% females, and younger population, and those who were literate, 83% graduate, actually responded on smartphones and internet, as you can imagine. The urban surveys have more males and more older males actually responded on telephones. So that's culturally, so more males and more older males actually responded on the phones. They were less educated, only 18% were graduates. The rural population was like 60% females, 56% above 30, and only 3% were graduates. These differences are important, in the three population. So you can see the level of education, three population altogether different. So those who have access to internet and smartphones are pretty different, and they are very small section of the population in Pakistan. Those who represent urban, again, they are more literate, but compared to the rural, they are still much better. So we use a knowledge, attitude, and practice questionnaire, a detailed questionnaire about signs and symptoms. We had set of questions, mode of transmission, high risk population, preventive measures, quarantine guidelines, and treatment practices, those which were available through CDC and WHO common, and it's an evolving knowledge also, as you can understand. And based on that, we developed an adequacy criteria for knowledge. So if you know 4 of the 10, signs and symptoms, which are the main signs and symptoms, then we said, oh, okay, you had adequate knowledge about signs and symptoms. And similarly, for attitude and practices, we developed the adequacy criteria based on the number of questions we had, and then converted into a binary, variables. So those who had adequate attitude and adequate practices based on the key practices which were listed on the left side of your, screen.
And you have three more minutes.
So based on that, we did, so these were the results. What we found is that electronic and print media and social media were more common among those who had access to internet. And those who were rural population, they actually believe on colleagues and friends quite a lot. About a third of the population had knowledge, but 2/3 of the population didn't have knowledge. One of the knowledge about preventive measure, which was circulated among the media, a lot of people knew about it. So the education about educating the people helps, that it shows. Just a couple of slides I'll give about the multivariate model we developed about the knowledge. So adjusting all the factors, so adjusted odds ratios are shown here. It shows that compared to the rural population, which is the red bar here, the urban and the those who had access to internet, about 2 to 5 times or 7 times had more knowledge about transmission, risk factors, prevention, and treatment. So that's a basic difference among the urban and rural and those who have access to internet. Knowledge also by education, if you look at that, again 2 to 9 times more likely those who had no literacy versus those who had undergrad or grad level literacy had better, quite high knowledge. And this is about the practices. You see the same differences. So strata wise, Again, compared to rural, the urban, and those who have access to internet have 4 to 5 times more knowledge. Education-wise, you see differences, but no difference according to age. One last question we asked about is the fear of COVID. So about 75% of the people overall had high level of fear from the virus, from the disease. They had 5 score or more out of the 10 when we asked them. So what we need to do, obviously, is how do we utilize the dumb phone to communicate through this, last mile communication we need to do for the rural population, the population who do not have, and these are the population who are about 65% of the Pakistani population who do not have access to most of the reliable, authentic information which is coming on the WhatsApp. So this is where we are making a strategy to reach out to those who do not have reliable information to protect themselves from COVID. So thank you, everyone.
Thank you, Dr. Zafar, for keeping in time. And I have a quick question. Did you ask in your survey about some of the mythology, conspiracy, and other questions that are circulating regarding COVID, or did you not?
We did actually. I presented it very brief. So our survey questionnaire has myths also. So like talking about, so a lot of rural population was talking about the mosquito bite can also transmit COVID, something like that. So and the treatment practices and herbal medicine practices and other practices. So all those detailed questions we had in our questionnaire about knowledge. So there were questions which were correct knowledge, but there were questions which were incorrect knowledge. So we asked all those questions. So we have a whole report, but I did not have time to present all that.
But in general, do you think that the majority of people know the right kind of sources of the COVID? They correctly identify it, or the majority do not and attribute to other causes?
So majority, as you can see, only 1/3 had adequate knowledge. So you should see these percentages.
1/3. Okay.
Yeah, 1/3. So 31, 34, 38. So most okay, of the aspects, they had 1/3 of the people knew about it, but 2/3 of the people weren't aware about all the aspects which they require to protect themselves.
Okay. Thank you. If there is a very quick question, otherwise we have to move on. Anybody from the audience has a question for Dr. Ajaz? Okay, then thank you, Dr. Ajaz. If you can,
thank you.
Dr. Zafar, sorry, can you stop sharing so we can move on to Dr. Ajaz?
Yeah.
Okay, Dr. Ajaz, can you share your screen, your PowerPoint?
Yeah, it's Assalamu alaikum. Ramadan Mubarak. Can you see my presentation?
Yes, yes. The floor is yours. Go ahead.
Okay. So we did this when it started with Pakistan, and before that it could reach Pakistan, and it was still in China, and we didn't have any kind of case in Pakistan. So we started to understand how to go about it, and on 26th of February we had first case imported from Iran because people from Pakistan, they went to Iran and they came back. On February 26th we had the first case. So we thought of developing, because everywhere in Pakistan people were talking about modeling and looking at the trends and comparing trends with other countries and trying to understand how the disease will progress in Pakistan and what would be the impact of it. So there were a lot of efforts, a lot of groups were working on that. So we chose SEIR model because different institutions in Pakistan, they were working on only on SIR model, but we also looked at, because this is suspected, exposed, infected, and recovered. So we also included the exposed one, and then we used our Shiny to model and to understand the disease. So we had some. This is just to give an introduction that as of now we have more than 18,000 cases. This is the yesterday's figure, 17,000 every day. Now we are getting 1,000 cases added to. The doubling time is now come down to 10 days. It used to be 12 days. Now has come down to 10 days. And at the moment we have more than 400 deaths. Testing capacity is being increased in Pakistan, and as much as tests are being done, more and more tests are being done. Because I just want to make one point here that most of the countries, the representatives and the audience from the countries are here, which see a very slow rate of infection as compared to Europeans and Americans and Italy and other countries. So in South Asia, in some of the Arabian countries, in other countries, we see a very different kind of picture, perhaps. And there are a lot of myths, a lot of talks going on. Some say that it is due to BCG vaccination. Some say it is due to the malaria drug that they've taken. Some other possibilities around them. But we are working on another kind of data in which we are trying to understand the time of onset and how these countries are catching up with the pandemic of other countries, and how much prepared they should be to make effective responses so that for their countries. So one thing is important here. I'll refer to one article from Egypt recently published, which talks about sporadic outbreaks in Egypt, and that's a very fine paper. Because we are also experiencing sporadic outbreaks in Pakistan in different areas, and with these sporadic outbreaks, the doubling time is getting reduced, and perhaps that's the thing that when we modeled this, because our work is under publication, but just to give an example how different provinces in Pakistan are doing, and you can see that different provinces have the different, and this all depends upon their testing capacity. So at the moment, on an average, Pakistan's positivity ratio is around 8.64, with provinces at different ratios. For instance, Punjab and Sindh, they have almost 9 and 11%. So there are many epidemic models available in literature, but we use SEI model, which is used to describe such outbreaks. So it assumes that individual and population is either susceptible, exposed, infected, or infectious, or recovered by or recovered. So, and they have got this immunity restored. So we also included the asymptomatic transmission, because at the beginning people thought that this is not being transmitted asymptomatically, but we included the asymptomatic transmission because now there is enough evidence that it is transmitting asymptomatically as well. So after putting all the assumptions in the model, we used clinical parameters. We also used the transmission rates. And there is a list of clinical parameters and transmission rates and assumptions which we used. So we took R naught as 3.2 and 3. Why we took 3.2? Because that was the first case from Iran, and Iran's average R naught, which is published in one of the articles, was 3.2. So we assumed the same one for Pakistan, and along with others. So you can see that time since introduction for the 0. If you look at 0 here, this is 26th of February, and from here. Numbers, and this is the population. We took whole population is susceptible population. Whole of the Pakistani population, we took it as susceptible one. And you can see the susceptibles, they start going down around the 100th day of the onset of disease. It still has to come. This 100 still has to come. Because as we start getting recovered, the more recovered you have, then the more the susceptibles they go down, and then your graph starts going back to the recovery phase. This is the peak time for Pakistan according to our model. They can be, this model is not perfect. We don't advocate this is something perfect. There are models or assumptions. They have the assumptions. They can be approximately correct. So according to our estimates, we still have to see this peak, and this peak is expected around, because we are here somewhere here, and this peak you see is expected like at this point of time. You can see the deaths, they are not much. You see, in fact, if critical, they are not much. But you can appreciate that severe infected and all others, they are a bit high. But after this and to the day 100, from day 65 to 100, there will be a sharp rise in even in deaths, even in critical cases, or and also the susceptible, they will start going down. So this is the time which is still going to come in from May to June first week, from May 15 onwards, May 18 onward to June first week, June 10. So approximately what we can say that about around from May 18 it will start. So this is
Dr. Ajaz, you have 3 minutes.
Okay. So this model was without any intervention. If we place interventions like non-pharmacological or pharmaceutical interventions like social distancing, lockdown, and another hand sanitization, face masks, if we do that, so this is something which we are going to have with intervention. That was without intervention, and this will be with intervention. So, and this we try to understand what will happen to our healthcare capacity of the hospital beds, because Pakistan has 0.6 hospital beds per 1,000 patients. And here you see that this is the upper limit for available hospital beds. And during the peak, there will be nowhere to cope up with the rush or with the patient load in the hospitals, and hospital beds that will not be available for those patients. So in conclusion, the Pakistan disease started 1 month later than most of the countries now seeing peak of the apid curve. Sporadic outbreaks confirm the phenomena of blind spotting before a peak that may occur. And model predicts peak at 90 to 110 day post introduction of first case. That's around May 25 to June 15. Burden on health system could be well beyond its surge capacity. Thank you.
Thank you. Excellent. Very, very informative, Dr. Ajaz. I commend you on doing this. And when is this publication going to come out?
We don't know, but I think nowadays this is being done very rapidly and without peer review. And this is something which we fear that it must go through a peer review, not without peer. It shouldn't be published without peer review. But I think there is an urgency that these estimates should be published, and there are a lot of publications are coming in.
Do you think that this model can apply to other neighboring countries similar to Pakistan, like where there's overcrowding and so on and so forth? Do you think that that others can also say in Iraq or in Morocco or others, it's about 110 days where the peak will reach, or do you think not? Is this unique to Pakistan?
No, the only thing is this, that if we know the R0, the base R0, and the RT, which is a real-time R of any country, if we can estimate it, we can easily predict. Because most of the countries, if they only a country which has R0 around 1 or below 1 or 1 point up to 1.4 may be doing good. But your assumption is important, that your first case was having what kind of R0? The first outbreak which you saw, did you calculate how many people were infected by one index case? So how many contacts or contacts were there which became cases from out of one case? If there were 2, 3, 4, or 5, or 6, because in some countries it went up to even 9. So when it is very, very rapid, and I fully agree with your assumption that the countries who are densely populated, it will be much higher.
Okay. Thank you. We're out of time, so I think what we're going to do is we're going to move to the next. If you stop sharing, but anybody who has questions can actually send it through the chat. So then at the end we'll put time for each person. So if anybody had a question for Dr. Zafar, Dr. Ajaz, please send it through the chat, text and write it, and then inshallah at the end we will we will go over these questions for each speaker. Okay, so going now a little bit more west, let's ask Dr. Ahmed Al-Delaimi from Iraq to present next. Can you share your PowerPoint, please? Okay, thank you. The floor is yours. Go ahead.
Assalamu alaikum.
Assalam.
Ramadan Kareem for all of you. In a quick matter, we will go and see the situation in Iraq for COVID-19. First, for the MENA region, we can see that Saudi Arabia is the highest cases. Iraq is in the brown orange color right here. This one also for MENA region. Iran consists of 76.4% of the region. The rest of the MENA 9.1%, and the Gulf region is 14.5%. First case suspected in Iraq, 22nd of February of this year. In Dakar, this is in the south. The Directorate of Health suspected a student. He is studying in Najaf and then tested in Dakar from Qom province. In Iraq, this is the status today, 2,153 confirmed cases, 68 new cases, 94 fatality case, and 1,414 has been recovered. Active cases 654, which is about 30%. This is from the WHO. Total cases per million is 54. The total tests through all the country is 95,000. The global humanitarian response plan for COVID-19 has received 600 million in funding out of 2 billion requested. A quick review on the incidence rate. We can see that Najaf, this is Najaf and Basra, this is in the south, 19.4, 10.3, and Baghdad, and to the north, Baghdad is the capital, 5.6, and to the north, Erbil and Sulaymaniyah, Erbil 8.6, and Sulaymaniyah 6.9. The male to female ratio, 1.2 to 1. Male is more, and this may be due to outdoor of men. Under 10 years old children, data indicates that children under 10 years old constitute about 7.5% of total confirmed cases. For the confirmed cases by age group in Iraq, we can see from this figure that the 40 to 49 years old is the highest rate, 20%. For the age-specific fatality of COVID, from 50 to 79 years old. This is the highest fatality rate. Facts that Iraq has thousands of confirmed cases, many times more than the number as publicly reported, according to doctors and a healthy ministry official and senior political. Some say maybe 3,000, and others said 9,000 daily result. The government of Iraq has opened curfew or the lockdown partial opening from 6 a.m. to 7 p.m. Friday and Saturday, total lockdown. Food production report to be stable till now. Approximately 20% of the cases in the Kurdistan region of Iraq. Restaurant can be can only delivery services. Shops, factories can come back online. Airport closure extended. Government offices 25% reopened. Gathering of more than 3 people in private cars are banned. School, colleges, places of worship, malls remain closed. Disinfectant and sterilization material have also been produced locally with the support of the government. WHO has collaborated closely with religious authorities in Najaf and Karbala, advising people observe religious rituals from the safe of their own homes. Limited resources in Iraq, whether artificial ventilator or CPAP, and gloves and others. This is after the partial opening. Iraq eased its coronavirus lockdown, and this is, we can see from the pictures, crowded people without precautions. Conclusion, COVID-19 cases in Iraq follow increasing trend. Number of carriers and cases more than presented in media. Stores, shops are filled with people with no social distance or precaution. Parallel to neglected and weak law enforcement, low rate of COVID-19 survey tests. Financial support is weak from the government due to 16 years of corruption. Shortage of hospitals, beds, and medical personnel, and absence of medical equipment, masks, and as we said, emergency and operational planning guidelines by the WHO to support country preparedness and response should be done in each governorate in Iraq. And thank you.
Thank you, Dr. Ahmed. You finished a couple of minutes before. So it seems like there is discrepancy between what the actual cases are and the numbers, because the numbers were relatively low, and also there were like 2,000 or so that recovered, and only I think what 5,000 reported or something like that. So it seems like there is a discrepancy of the number of cases. Do you have a feel, or do you know about the hospital situations? Are they overwhelmed? Are they you know, have you any idea about the situation in hospitals?
Well, in Anbar governorate, which is west to Baghdad, in the ICU we have only 3 to 4 artificial ventilators for the whole governorate. This is for Anbar. So the situation is bad. They are not prepared for increasing cases. Till now, you can say it's not pandemic in Iraq, but is it real? The real cases, the real number, we assume that it is more than that announced by the media, because the testing, COVID testing is in a low rate, only few thousands.
Mm. And then based on what you said, the first case was in February?
Yes, February.
So if we say use the model that was presented by Dr. Ajaz, about 120 days or so, which is about 4 months. So till the peak. So that means March, April, May, and June. That means the peak is still maybe not reached in Iraq. Potentially.
We saw figures showing that it's increasing in April, end of April. It's increasing.
Right. Yeah. And it's clearly that showed the pictures of the mixing and outside. This is really bad. The social distancing is not practiced. No masks, and that's definitely going to be a problem. Because you finished 1 minute early or so. Anybody has a quick question, or if they want, just kind of send it a text.
I have a question.
Yes, Dr. Zafar, go ahead.
Yeah, so I have been wondering because this Iran has been badly affected, and mostly it was said that, Zairine who goes to Iran and Iraq combined, they get infected. So obviously they go both places, not only in Iran, but also in Iraq. But even if we consider this underreporting, you can't really underreport the deaths. And the deaths you still can count. So we don't see that much of deaths in Iraq, which is a good thing, obviously. But I'm wondering why this is there. Iran has been so badly affected, and Iraq not so. Is there a reason for that?
Comparing with the total cases, confirmed cases, if we compare it with other countries like Iran or USA, I think it's the same.
Oh, the deaths are similar? Deaths?
Yeah, because we on media, it says only 2,000, let's say. If it is right, and you divide the death over the confirmed cases, and we compare with other countries like Iran or Pakistan or USA, I think it's near, even lower. Yes.
Okay, so maybe then there isn't that widespread of cases as these reports are saying, if the deaths are lower. Go ahead, Dr. Abdullah. I think your mic, just a second, let me. Dr. Abdullah, now we can hear you. Go ahead.
Okay. This is my presentation about COVID-19 in Yemen under the title "A Single Case and Multiple Question." Really, I prepared this presentation more than 4 days before, but in the last 2 days we have new data, and I update this presentation today. Anwar. The first slide. Oh, this is the last slide.
Okay, yeah, just move it up and double click on it. Go to the first slide.
Yes, wait.
Dr. Abdullah. لا على الجهة اليمين أصعد إلى النهاية إلى الفوق. أيوة اضغط كمان أيوة select the first slide. Yeah, double click on it.
Okay.
No, on the first slide. Yes, double click. Yes, you can do that.
Okay. So from a biblical point of view, Yemen with 13 million people population, but facing complex emergency like cholera, diphtheria, dengue, malaria, chikungunya, measles, and respiratory infection, and as well as now COVID-19. Before start the occurrence of cases, all government enter the preparedness phase with the support from WHO. 37 isolation center established, training of doctors and health workers. All entry points are officially closed, but in reality, this is not sure. School and universities in Moscow were closed since 16 March 2020, and schools and universities, it's still now closed, but Moscow now open. In the response phase, the first case of COVID-19 was reported by Ministry of Health in 10th of April from Hadramaut region at the south. The case was isolated and treated in the isolation center. Contacts were followed, but very limited number were investigated. Shortage of unlimited diagnostic capacity is a problem. Before 2 days, new data come from Aden. 5 cases were reported as confirmed case from Aden in 29 April. And yesterday, just yesterday, 1 case report from Taiz in 1 May 2020. My presentation about the first case occurred in Hadramaut in 10th April. This case is not imported case, it's endogenous case. And it is report from a Shahar city at Hadramaut Governorate at Styrian of Yemen at the Arabian Sea. This case was identified in private polyclinic and there's no data about exposure. This case is a patient, as a male patient at age about 60 years. It is a Yemeni resident. His work as a manager of a Shahar seaport at the Arabian Sea. The onset of symptoms is in 4th of April 2020, and date of reporting and take expense was 8 and 9 April 2020. Clinical presentation, fever and cough, breathlessness, and patient is heavy smoker. This case come to Polyclinic for medical consultation in 7th of April, as the doctor who see this case said. And this doctor reported to surveillance, local surveillance team after he had a doubt about CT scan image. 2 independent nasopharyngeal swab were taken from the patient by rapid response team and sent to regional PCR unit. PCR result said this is a positive case. Patient isolated and treated in the isolation center and be cured after 14 days. Also, 18 close contacts were identified, but only 2 of these contacts were investigated and being negative for COVID. Another 209 close contacts were identified, none of them were investigated. No further cases were reported in Hadramaut, but after 3 weeks, 6 cases were reported in Aden and Taiz. The case definition must be updated, because now the surveillance officer don't support this a suspected case unless there is epidemiological linkage, unless there is history of travel coming from epidemic country. This case definition need to be updated now because most of cases now are indigenous case. There is limited diagnostic capacity, so there is limited swab to investigate the suspected cases. There's no active surveillance. All the cases reported through the passive surveillance. There's a complex problem, especially in Aden after a week of rains occurred in Aden last 2 weeks. There's a lot of dengue and chikungunya cases, and this led to misleading about the COVID reporting. Many health professionals in Aden said this is a dengue outbreak. Some say there is a COVID outbreak, and then, till now they are confused. Even in the hospital, in Aden, private hospital working well. This private hospital where all patients go to them, some of this private hospital are closed and not accepting patients because the stigma of COVID. Another problem is the political instability, especially in Aden. So this first case in Hadramaut was occurred in 10th April, and now we are in 2nd May, and only 6 cases reported last 2 days in Aden and Taiz. This first case gives multiple questions. How the exposure occurred? No one knows how the exposure occurred. This index case in Shahar, but it is not the first case. Sure. Where they are why there are no cases among the close contact? why there are no further cases reported in Hadramaut? Even if there are no confirmed cases, how much are the suspected cases? Is it possible that only single case in Hadramaut for this long period of time? Are there association between the first case reported in Hadramaut and the 5 cases reported in Aden after more than 3 weeks? May dengue or chikungunya occurring at the same time with COVID? That means, is it possible to occur 2 or 3 epidemics at the same time in the same locality? And the last question, can doctor depend on CT scan for diagnosis of COVID-19, or it is necessary to do PCR? And thank you. And this picture of the Mukalla city, the capital of Hadramaut. Thank you.
Thank you. Thank you, Dr. Abdullah, also for keeping to your time and less than 10 minutes. This is a very interesting. This is very interesting case. That you believe it's indigenous. So are you saying there is no travel to Yemen? I mean, nobody could travel to Yemen. So
No, there's a lot of people coming from outside Yemen.
Yes.
The border is not surely closed. This case from Al-Shahr is a manager of the seaport, and there's some Gawar, Yemen and Emirat. Some people come with goods in this port, and this manager has contact with those coming with the goods. But the government said all the entry of point closed. And even the border from Oman and Yemen, still people pass.
Yes. So maybe it's not indigenous because we haven't heard of any well, there was one case in California here that is indigenous, yes, that is not related. So maybe yes. So there isn't. Yes. But do you think that Yemen now is going to start to have this spread, or it is there and not known? I mean, what's your assessment? Do you think it is just starting?
No. Yes. There is a cases, but there is a problem of very low sensitivity of the surveillance. Many cases suspected not investigated because there is no swab. In Aden, I asked yesterday with many health professionals in Aden what the new data said. Yesterday, 16 deaths in Aden due to fever. It is sure this fever not due to dengue or chikungunya. It is sure most of them due to COVID, but not one of these investigated. I personally contact with relative one patient have breathlessness and fever and being in the home. The hospital not accept them. After 3 days, I ask the surveillance, they go to do swab for him for PCR, but the patient die after some hours.
Wow, that's really scary and very sad because of the situation, yes, the conflict, yes, and the war in Yemen. And then if this spreads, this is not gonna be stopped.
Yes,
really, yes. Any quick questions for Dr. Abdullah? Or if you want to do it in the chat as well, we can answer it. But
yes, Dr. Wael.
Yes, go ahead, Dr. Ahmed.
Dr. Abdullah.
Yes.
Can I ask a question?
Yes.
What about the NGOs and WHO? Are they doing their work about COVID? I mean.
Yes, WHO support the isolation center. WHO support the training of doctor and health workers. The problem now about the personal protective equipment is lacking, and the swab for laboratory is lacking. Yesterday, I speak with one officer in WHO. I said to him, the Aden, there's a tragedy in Aden, and there's a lot of cases, COVID, maybe dengue, maybe malaria, and said all the international donor, the Orca official, all come out to Aden now. Only few Orca because this political instability and the COVID. But there's now in Aden establishing joint committee between different partner, local partner in Aden, and I contact with them. And maybe suppose maybe after 2 days, maybe I go to Aden to join with them. And I will ask with the WHO and other international to do a lot. Yesterday, I heard that the organization of Doctors Without Borders can manage the isolation center in Aden because there is limited doctor in this center.
Thank you.
Thank you.
Thank you. Thank you both. I think we'll have to move on, but this is a situation we would be interested in monitoring as we go on. Let's move on now north, going to Palestine. And Dr. Adnan, maybe you can tell us with the presentation about Palestine. So Dr. Abdul Rauf says, you know, Yemen is facing the greatest challenge due to other complications like cholera, and yes, that is one of the many complications. Yemen is going in a very serious situation. Okay, Dr. Adnan, the floor is yours.
You have to unmute him.
Unmute who?
Dr. Adnan.
Oh, okay. Okay, Dr. Adnan, we hear you now. Go ahead.
سلام للجميع، كل عام طيبين. It is my pleasure to present about COVID-19 in Palestine. This is with sharing my colleague, Professor Abdul Rauf al-Manama. As you know, in Gaza, in Palestine health sector, we have a number of key players: the Palestinian Ministry of Health, UNRWA, NGOs, WHO, private sector. We listed the map. Okay, this will be enough. Until 29th of April 2020, we have the cumulative number of confirmed cases in West Bank. We have 342. In Gaza Strip, we have 17. The recovered cases, 83 in West Bank, 10 in Gaza Strip. The active cases in Gaza Strip, 7. The number of deaths till now, 2 from West Bank, but no death cases from Gaza. The total number of blood samples tested for COVID-19, 27,800. For the clinical symptoms, we have the tested cases for COVID-19 Gaza Strip were asymptomatic. Only 2 cases suffered from slight rise in temperature. In this regard, WHO have engaged in the activity against COVID-19, and WHO provided technical guidance to Ministry of Health on case finding, contact trace, quarantine, isolation of cases, surveillance across the occupied Palestinian territories. Also, WHO provide testing kits for laboratories, swab for collection, laboratory supplies, etc. Also, PPEs, drugs, medical disposables to use in health facilities designated to treat COVID-19 patients in Palestine. Also, WHO supported the training sessions for health staff in Palestine for infection prevention and control and case management. Also, WHO conducting assessments and monitoring visits to identify the needs and the situation reports and monitoring the response activities and issuing clusters bulletins. Also, education and actively communication with the public through risk community and community engagement through printing and distributing hundreds and thousands of brochures, posters for the public, and using social media for this regard. Also, WHO has leading the coordination with the health cluster consisting more than international and national NGOs as a response to COVID-19 in line with Ministry of Health plan. Also, we might talk about the Ministry of Health response in Palestine, either in West Bank, Jerusalem, and Gaza Strip. They established the National Emergency Committee in both West Bank and Gaza Strip. Also, the most important thing is the compulsory quarantine. And this was very important to respond to COVID-19. Daily press release from Ministry of Health, emergency telephone number, which located to answer the public queries, procuring medical supplies, drugs, treatment, tests for COVID-19, preparing protocols for dealing with suspects and protocols for screening the situation. Medical staff training also was very important, securing quarantine places, either was hotels, schools, like this. Also intensive health awareness for public through lectures, poster, radio, TV, social media, transparency and updates reflecting the situation in both West Bank and Gaza Strip. Also, there was a very important decision to close schools, universities, and mosques and parks. This was important and was taken very early, establishing technical and advisory committees to manage the crisis, coordination with WHO and the private sectors and NGOs as well. There was very important decision for the Ministry of National Economy how to deal with workers, sellers in markets, and this was mandatory to wear mask during the work. For Ministry of Health response, especially since 15 of March 2020, all travelers coming through Rafah and Beit Hanun, you know, Gaza Strip has two exits, Rafah with Egypt and Erez with, or Beit Hanun with Israel. So there was excellent decision to make compulsory quarantine for travelers coming from the two exits, and this is very important. And there was isolation hospitals. We have the Al-Maidani Hospital and European hospitals. The quarantine facilities reached to 29 centers in Gaza Strip, including schools, hotels, primary health care centers, and hospitals, and are distributed through the 5 governorates of Gaza Strip. As you know, Gaza Strip consists of 5 governorates: Rafah, Khan Yunis, Mid-Zone, and Gaza and Gaza North. So there are many activities and decision taking.
Dr. Adnan.
Okay, sorry.
3 minutes, 3 more minutes.
Okay, so the hospital is designated for the receiving quarantined people for the pre-existing medical conditions, the European hospital and the Sadaqa hospital. The file of the patient labeled with quarantine, and they followed the SOP in dealing with patients. The quarantine period reached from 14 to 28 days. Period to discharge, they tested by PCR. Also, the places was sterilized before receiving new quarantined people. Public primary healthcare delivery was limited and closed just for receiving emergency cases. Wedding halls and weekly open markets were closed to not allow for people to gather. Ministry of Health suspended the work at outpatient clinics. Also, Ministry of Health make appeals to the United Nations to open the blockade on Gaza Strip. We would like to emphasize and focus on two main points: the perception of public emergency committee for health awareness at Islamic University of Gaza was unchanged. Social distance in pharmacies, bakeries, and supermarkets was followed. Stay-at-home list movement. But we still, as a conclusion, we still have high risk factors. The entrance of infected person from the crossing with Egypt and Israel, the return of workers who are working in Israel and enter West Bank. This is very dangerous. It's still ongoing. Ignoring some of the public to Ministry of Health advice and guidelines in markets. The pressure of the public to ease the restriction measures. I think we lost the photos because I don't know why. So there are some photos explaining the commitment of people in markets. Anyway, thank you so much for your listening.
Thank you, Dr. Adnan. So we're out of time, but just basically, it seems there are very limited cases, and that these cases are, very well followed, and you don't feel there is, or maybe Dr. Abdul Rauf also can mention, there isn't a widespread problem. So it seems it's contained as far as you are aware.
At least in Gaza Strip, all the positive cases are under quarantine. They did not enter the Gaza. There is no inside cases at this time, and this is the thing that the Ministry of Health and all stakeholders are trying to do to prevent the disease from entering into Gaza, and that is really a miracle that is happening in Gaza.
Yes.
But the situation is still just in West Bank. There is daily detection for infected cases. And I think this is due to the entrance of workers from Israel to West Bank. As my colleague, Professor Abdul Rauf mentioned, it is contained in Gaza Strip, alhamdulillah, because we have limited exit just from Egypt, and this is coordinated with the Egyptian to how to do with quarantine.
Yes, and then we have a few comments very quickly saying, Dr. Zafar saying, is this because of limited travel to Gaza? And I think you answered that. And there is, I believe Dr. Abdul Qadir is saying that there are only 5 active cases only, and only 12 cases. That seemed like very small. So it seems that things are controlled in Gaza. But thank you. In the interest of time, I want us to move forward, and I would like Dr. Miram, please, if you can join and share.
Hello.
Yes, we see it. Go ahead, the floor is yours.
Okay, great. So actually, it's Miriam.
Miriam, I'm sorry, I'm sometimes
hello, it's okay. Hello everyone, and Ramadan Kareem. So actually, I'm going to talk about the experience of Lebanon in the management of coronavirus. And I chose to talk about the timeline and milestone, the epidemiological data in Lebanon, the strategy adopted by the Lebanese government, the key factors of the Lebanese experience, and then how the next step and the future plan, how to suppress COVID-19 transmission. So regarding the milestones and the timeline, actually we're similar to other countries. The first case was, the first confirmed case started on February 21, and it was a woman who came from Iran. And directly after 1 week, in February 22, we closed all the educational institutions. And we'll see later on that it was a good decision, at least in the strategy adopted by the government. On February 29, we had 7 confirmed cases that were admitted to a specific hospital. It's a governmental hospital in Beirut. It was assigned to receive all COVID-19 patients from the whole country. On March 6, we closed all the gyms, cinema, theaters, nightclubs. It was in order to close everything related where we have a crowd and we have close contact. The first test took place on March 10, and at that time we had 52 cases, confirmed cases of COVID-19. On March 11, they closed restaurants and they banned all flights from 19 affected countries like Iran and China and other European countries. And the country was declared actually an emergency situation also on March 15. And before March 15, actually, we had, because we started with one hospital in February, in March 13, the government assigned 8 governmental hospitals to receive cases. Each hospital in a district or actually in a province in Lebanon. And then we closed the airport on March 16, all borders and seaports, and we started what we call a self-curfew with lockdown measures, and then partial curfews with all the with checkpoints, and the Lebanese army was on the roads to stop people because we had a plan for the curfew. And on April 22, we had the first case reported in refugee camps, because you know that we have almost around 1.5 to 2 millions of Syrian refugees in Lebanon. So in April 22, we had 682 cases. We'll see today the total number of cases as per the Ministry of Public Health is 733 cases. And we had at that time 22 deaths. So the same restriction that started in March are extended till May 10. So I wanted to show just Lebanon. You all know maybe Lebanon and actually the geographical localization of Lebanon among the other Arabic countries. If you want to talk a bit about the data that we have in Lebanon, the Ministry of Public Health has managed, and specifically the epidemiological surveillance program at the Ministry of Public Health has managed to collect all the data and centralize all the data from all the hospitals, and to publish, the official data was published by the Ministry of Public Health. So you can see that it started in February 21, and this is the curve that we have. And this data, the cases are till actually April 29. And the total cumulative for till April 29 was 725. Today is 733. If you can see the picture, the slide here would show us that we have different distribution per district or per province. And mainly, we had the most important cases in Beirut and in Matan area. And this also was related to the number of tests conducted first in these areas. If you want to take the origin or the exposure data related to these cases, actually 56% of these cases were contacted, confirmed cases, so it was through contact. 24% traveled, and we have 15% still under investigation, and only 4% without any identified source of data. Now, if we want to take the data or interpret the data by age group, you can see that the most important category affected is between 20 and 29 years, and actually it's different than what we saw in different countries, I guess, and other countries, and what we can see, let's say, in Italy or other European countries. We can discuss this later on. And if we want to take the ratio between male and female, we can see as we saw in, I guess, in Iraq, we have the same, almost the same ratio, male 54% and female 46%. And for the clinical presentation, we had 24%, almost 24% of asymptomatic cases, and 66% of moderate to mild cases, and for the severe were 9% of cases were severe and critical cases. So what was the strategy adopted by the Lebanese government? I wanted to start with this graph because it shows the positive cases, at the same time the number of tests conducted and the percentage actually of tests conducted. And we can see that we started at the beginning with only 200 to 250 tests per day, and then the tests has now reached 1,550, and the plan is to reach 2,000 per day, even 2,500 per day, in order to make sure that we're containing the virus. So the strategy, since we might know the Lebanese context, might know the economic situation and all the challenges that we're facing since years. So the government chose to flatten the curve while increasing the capacity of the healthcare system, so we can adequately respond to the pandemic. So it was the only solution, and I guess it was adopted by other countries because we don't have enough resource. We have important human resource at the level of the healthcare system. They are very knowledgeable and they have important capacities, but as infrastructure, we don't have really enough material. So they work on an estimation of 5,000 cases. So they consider that from these 5,000, we can have 20% that would need hospital care, almost 1,000 cases. And from this total cases, we can have 5% in need of intensive care, which is 250 patients, and around 150 who needs mechanical ventilation. So in this scenario, they consider that with the 1,000 that we have, or the 1,000 patients that might suffer from COVID-19, they will not be accepted or actually admitted at the same time at the hospital. So we will have people admitted, and progressively they would be discharged, and then they can manage the situation. By this scenario, we had to make sure that we have almost 263 ventilators, and as you may know, in all countries we have a shortage. So the plan was to have this ready by April 1, before the peak of the cases. They work on the enhancement of the epidemiological surveillance unit at the Ministry of Public Health, and they activate the emergency plan at different public hospitals and private hospitals. And I can't remember if it was actually in Iraq or Palestine, but private hospital at the beginning, they were not accepting to take COVID-19 patients in charge, and then they all adapted and started to receive patients. But they defined 5 university medical centers that can conduct tests, and then they can communicate with the Ministry of Public Health, and they can send the results and receive COVID-19 patients. And a hotline was created by the Ministry of Public Health in order to receive requests and be contacted by potential patients. At the same time, the WHO has played a very important role actually in defining this strategy with the Ministry of Public Health, and at the same time following up on the ground. And actually the different hospitals, one of these hospitals was a mobile lab. They had a mobile lab, and they are conducting tests in different districts, so that we can have a kind of sampling, which is not really, not studied sample. Mainly it's a rough sample, so we can have an idea about the cases. And we had a series of complementary actions. It's similar also to other countries.
So mainly, if you can try and finish quickly.
Yes. So these actions are similar to other countries. So we closed the borders. We canceled all the big meetings, restriction of public gathering. All churches and mosques were closed, and universities had the lockdown and all the restriction on activities. The key factors are that we have a limited public transportation. We have taxis, but we don't have, let's say, subways, and the population compared to other population is younger. We closed very early the educational institutions. the population was really committed to the media, and the limited resource due to the economic situation has pushed the individuals to stay at home and be really aware. I have 2 words to say that in these 3 weeks, we're in the 2nd week, we're increasing the test, and we're doing the test on asymptomatic and healthcare providers, and we're taking random sampling, mobile applications were developed to locate potential patients and to collaborate with the municipalities so they can do screening and test. Now we're starting with the lockdown exit per sector. Still, we're lifting to keep the social distancing or the physical distancing, and we're going to start with activity that don't need really lots of physical presence. To finish with my presentation, I just wanted to mention this quote. This is a world problem. This is a world public health crisis. And this is an opportunity to all of us, not only in Lebanon, to rethink about the health system, the healthcare system in each country, because this virus or this pandemic has shown that lots of healthcare systems are really suffer from severe problems, and they are not really ready to face such challenge. So it's an important chance to rethink about our system. The 3 questions that remain here is that they are talking about a 2nd wave, depending on if the lockdown is lifted, if people will accept or not, and we saw different models at the beginning. So they are tentative. Actually, they are different questions and different discussion in the country. Some epidemiologists said that there is no 2nd wave. We have to wait and see once the lockdown is lifted. If the Lebanese population would follow the preventive measure to flatten the 2nd wave curve, due to the economic situation and the population protesting in the street now, so we will have to see if they would commit to the government decision and would stay at home in the 2nd wave if we have a 2nd wave. Thank you so much, and sorry if I took more than 10 minutes.
Yes, thank you, Dr. Miram. Yes, you went over time. So we'll just kind of go to the last presentation. And if anybody has comments, they can do it through the chat to Dr. Miram. Dr. Idris, please go ahead. Okay, the floor is yours, Dr. Idris. You have your mic on? Please put your mic on. Okay, I unmuted you. Go ahead.
Good morning, everybody. Ramadan Mubarak. We have a good meeting this morning. I will speak to you about the evolution of coronavirus in Morocco quickly. The first case in Morocco appeared in March, 1 case, and also 1 case in Tunisia, 3 cases in Algeria. But Morocco, under the reign of His Majesty King Mohammed VI, may God the glorified, was very committed to the part of sustainable, industrial, agricultural, artisanal, touristic, and human development. World Health Organization declared international public health emergency on January 13, and also a pandemic on March 12. As the initial alert relating to this new virus, Morocco has started the preparation process to deal with it and has developed its national monitoring and response plan to COVID-19. Our country, which for social distancing, consisting of the closing of land, air, and maritime airport since March 15. Stopping study of all schools leveled and academic from March 16. stopping prayer at mosque, and progressive containment of the whole population since March 20. The first imported case was detected on March 2. The first case of local transmission was recorded on March 30. And the number of confirmed cases has gradually increased. Morocco has prepared hospitals, also public and like in this public, private public, Sheikh Khalifa. Also emerging hospital by transforming the fire of Casablanca in a hospital wholly equipped in 1 week. Morocco had to learn to react quickly to this unprecedented crisis, while sometimes multiplying by 10 its later capacity as much as its capacity to diagnose the disease. At the start of the crisis, only 3 laboratories were equipped with the polymerase chain reaction, PCR, to detect the presence of coronavirus SARS-CoV-2. Pasteur Institute in Casablanca, National Hygiene Institute in Rabat, Mohammed V military hospitals in Rabat. Morocco steps up coronavirus test. 6 other university hospitals, Casablanca, Rabat, Marrakesh, Ouzdafas, Agadir, started conducting coronavirus tests, bringing the number of total laboratory testing for COVID-19 to 9, as many other in different regions as being prepared to the same task. A slogan launched on March 16 by the World Health Organization, test, test, and test. Since March, Morocco has increased its COVID screening capacity to test per day to 2,062 tests per day. The recent import also of rapid serological tests, 200,000 kits, have just been received by the Kingdom of Morocco from South Korea to strengthen screening for COVID-19. All these measures and others have led a real slowdown in the spread of the epidemic. While the total date today is 171, if they didn't take measure, we will have today 8,000 days. Confirmed cases are about 4,569. Persons who are healthy 1,083, and negative analysis about 32,000 cases. There are also a difference by region in Morocco. There are regions who are not very contaminated, like Sahara, L'Ayun Saqiya El Hamra, 4 cases, Dakhla Wadi Dahab, 2 cases, but there are also regions who are very contaminated, like Marrakesh Safi, 1,004, and the region of Big Casablanca, 1,157. The same result about the region. The north is more contaminated than the south. Perhaps daily coronavirus case, we show that the evolution is like normal cross, the curve, Gaussian curve. It will with the maximum about April, and it's decline to fall about May. Daily delta about 1 to maximum 12 days, 1 day. The total coronavirus case cumulated, the curve is progressive. Morocco is among the countries weakly impacted by the epidemic. Why? This result was not possible thanks to strategic decision, early border closing, travel ban, containment of the whole population, intra-city travel must have an authorization, obligation to wear a mask, medication with hydroxychloroquine, and antibiotic azithromycin. Here we can see the famous Jami' al-Fna at Marrakesh, who normally is clouded. Now it's empty. Also in Rabat, Casablanca, the government stopped all activity, and if one want to go to travel or to work, he must have authorization. Also, disinfection of all area, public, and here in the Garway. As a result of the work stoppage, many families has suffered from poverty because there are no work. The state has distributed basic necessity to poor family, gave financial aid to family by the program of family aid, some money like 1,000 dirham per person, has housed local after and feed the homeless in the area, and also has hosted and feed illegal migrants who can be source of contamination. Progressive deconfinement may perhaps begin on May 20, and welcome to Morocco. Thank you for your
Thank you, Dr. Idris. Very nice, and within 10 minutes. Thank you. I think it's positive news. We ended with positive news about the region, in that Morocco seems to doing well in controlling the situation. So if I want to summarize, it's very interesting what we have. So we have Pakistan, who is having an understanding of what's going on, but that the peak is still to come. And the models and the attitudes that we saw, it seems that we still are going to see that coming in the next 1 or 2 months. And then we have the situation in Iraq is unknown because the data is not very reliable, and there isn't following of the protection and social distancing, so the risk is there high. Yemen is very high risk because there is no real understanding and testing, and people are diagnosed and dying from COVID without anybody even identifying them. So that's a very serious condition, especially given all the challenges. And then we have another good news situation with Palestine, and that there seems no cases and no spread because of early restrictions, and because there isn't a lot of travel. Lebanon, so far it seems good. There isn't a big spread, but the risk is that it could come again, and that is something that is given a lot of complications, and there are refugees and so on. So that is also a question mark. And finally, in Morocco, it seems the peak has been reached based on the data, and things are going down, and the testing is very extensive. So we are all appreciative of all these presentations. I want to open it up now for any comments, questions, discussions, and then we can wrap up in 15 minutes.
Yeah, thank you very much, Dr. WAEL, and everybody who has presented. I'm Ijaz from Pakistan. I have a couple of comments. One thing is important, that our region is having this outbreak at a similar time, in and around at the end of the February, early March. So most of us are going to have this peak as we modeled. So perhaps it could be the same time. So the region has to come up with a combined strategy for the next 1 month, how to deal with combinedly, because most of the countries, apart from a few countries, the rest are all developing countries. So they must put in resources, put in innovative strategies combinedly to fight it out. you see, Morocco has done good, Palestine has done good, Lebanon is going very fine. But I've written there is a chance that this virus, we don't know the genotype of the strain, the strain that each of these countries have. It is important to know exact RO of this virus, because this virus has a capacity to mutate. It has already mutated. So in coming winter, it might mutate again. So this is something which most of the scientists are also talking about it. So that should also be kept in mind, and we may relax or at some places, but by calculating the real-time R, once you have the real-time R, that how much this virus has slowed down traveling from one person to the other person. Because, for example, if in the beginning it was one person was infecting three persons, and after putting in the set of interventions, not just one intervention, a set of interventions, this R has come down up perhaps near to 1.2. Until unless it comes down below 1, the lockdown and the intervention must not be relaxed. Because if you relax them, then you are inviting virus to replicate much speedily and in larger populations and within the population pockets which do not have the immunity. So then those outbreaks will happen, and a new wave will come in with a bigger R naught, maybe 4, 6, or 7. That has to be cautioned. Thank you.
Thank you, Dr. Ijaz. And just to kind of, in case somebody missed it, the R naught is the spread, the speed of spread, or the likelihood of spread. And R3 means that one person is going to spread it to 3, and so on. So I agree that unless it goes to an R1, that means only one person is transmitting to only one, then the risk is very high. And that's where the data is very important. The more we have data about the speed of the spread, the more we're likely to understand the risk and the curves. And I was very concerned that you said that there is a potential mutation. If there's potential mutation, like the influenza, then we're in big trouble. Then this is really not going to end in a year or two, and maybe more. So that's a real concern. Any other comments?
Dr. Wael.
Yes, Dr. Abdurrahman.
I was listening to the last segment about the mutation, and in Gaza we advised that we have to make a whole genome sequencing for the virus or the isolate that was found in the 17 cases in Gaza. And this advice is, I think, is applicable to all countries because of the high rate of mutation, which I think have reached 2% of the genome, of the whole genome of the virus during a 4-month period. So this virus is very much unstable. This would also complicate the vaccine production process also. And if you try to explain the differences in mortality rates in different countries, it might also be related to the strains of the viruses. So I think we need to whole genome sequencing for every country and continuous update on that issue. The second comment is most of our countries, the Arab countries, really did not have a preparedness plan for this pandemic. And they started to cope with the epidemic just according to the WHO advice or the CDC. Therefore, this a lesson that should be learned from this pandemic, that each country would have to prepare their own preparedness plan for any future pandemic. Thank you.
Thank you, Dr. Abdurrauf. Any other comments? So I mean, the gene sequencing of viruses, if it's a collaborative effort, it can really help the region advance in terms of trying to develop vaccines, or, you know, I do want to share one good news is that one of our colleagues in Jordan has came up with a new testing kit that is using a different method, and now it's going to be produced by Finland, by a company in Finland. And the aim is to produce it cheaply, and it's a different way of looking at the RNA. I'm not, an expert in that area, but that is where today everyone is on the same level. The US is not better than, Pakistan, and Europe is not better than, Lebanon or any of these countries. Everyone is on the same situation. Nobody knows what's going on. So there is an advantage that countries can come up with their own solutions and their ideas. Okay, if there are no other comments or discussions, then I think we can close. And I really appreciate all the effort you have put, and I think this was a very good, successful. Dr. Abdurrauf, you wanted to say something? You raised your hand.
Just last word. Can you circulate the presentations that were presented today to all participants, or this wouldn't be possible?
I will ask. I'm also planning, the video is recorded, and I'm gonna, with your permission, I'm gonna put it on YouTube for people to see it and circulate it. But I'm also, if you want to send, you're all on the email list. So if you want to send your presentation for everyone, please do so. You are all in the same group email. So yes, we'll ask for that. Okay. Any other comments? Anything? Yes.
Yeah. Well, I would. I'd like to ask you to disseminate the recording among the people who attended, not put it on YouTube. Okay. Yeah, I think that's better because, we need to keep some information for ourselves. Yeah.
Yes. Okay.
And I'd like to thank everybody who participated. I think it was a very good webinar. We got a lot of good information from other countries.
Yes. Thank you. I appreciate that. And I'll follow up with you, Dr. Nargis, about this. Okay. So thank you very much, and have a good breaking of fast. Some of you already probably started. Okay.
Yeah, we already done.
Thank you.
Bye.
Thank you.